Yesterday we received a lot of information about the program itself and of the impact of the program, and that it definitely has an impact because there's scientific data saying so. But now we have people here on the stage telling you what this program meant to you. Mrs. Calotti, I'm very delighted to welcome you here and that you are going to share with us your experience. Because as a patient, sometimes it's not easy to join this panel. So give a warm hand to Mrs. Calotti. Mrs. Corinna Calotti, she is a social scientist by training, and she has been retired for 6 years. She suffers from fibromyalgia, asthma, allergies, thyroid problems, and since autumn 2021, she has been the head of an INSEA course in a peer-to-peer program. So she was not only a participant, but she is also the teacher of a number of courses. Mrs. Lorick has said that this is about passing on the power of patience. In 2019, you attended your first INSEA course, and how did it come to your attention? Actually, I saw it online. I was looking for such courses, all on my own. Yeah. And then you attended this 6-week course with 12 participants. What was your experience? Because you were a very experienced patient, so to say. I've been ill since I was 13, and so I was part of the system, but I received very little support. And during this course, what I liked about the course was that the exchange between patients was very important. This is what I appreciated very much, and I think it's a good thing that it's not health practitioners teaching the course, always using very medical terms. And I have this social studies background, and I may understand this very technical language, but I want all the patients to understand what's being said. And of course, there are hands-on aspects that are really useful, that you can really use in your daily routine. Now, what is it that you can really use in your daily routine? Well, of course, you need medication, but sometimes there are alternatives. And I'm talking about relaxation, physiotherapy, nutrition, which can be very important. So all the other factors that are important, and also how to deal with physicians or health practitioners, because this is what you need to deal with. And sometimes you feel, well, very alone. And what was particularly important to you? What was particularly helpful? I really loved the action plans, because this is what you can read together with the other patients, and you can develop them yourself. And whenever I'm ahead of such a course, I really like reading these action plans, because sometimes I tend to forget about them. And whenever there's a new class, I can read them again and realize how helpful they are. And then I realize how to prepare for discussions with experts. You started this course in autumn 2019. This is about 3 years ago. When looking back, we saw this curve from Mrs. Dirks and Mrs. Lorick. First of all, there is an improvement of life quality, and then the same level is maintained. What do you think? What are the changes that you have experienced? What is better about your everyday life? Well, I feel more powerful. I feel empowered. I have multiple chronic conditions. Often you feel very powerless, and you go and see a doctor. And I really like the idea that there is this across indications approach. I can go to a group of patients suffering from fibromyalgia, but it's really about empowering you, because I'm much better with my self-management. And what do you do differently now? Well, self-efficacy. This is particularly important, because physicians sometimes say, well, there is an indication for you, but I don't know whether it's going to help you. This has a huge impact on patients. If I believe in what I do, that this is the right thing to do, that this is sustainable, this can help me, and then I will try new things, and this makes me feel better. But you do not only have the role of a patient, but also the role of a head of a course that you do as an experienced patient, and you have taught a number of courses with people with different indications. And what is the feedback that you have received? What is important to these people? First of all, I've often been told that we have a level playing field here. This is not about being a teacher and the others are students and holding presentations. No, this is about a level playing field, a peer-to-peer approach. They are also relatives of people with chronic conditions. They realize that this is authentic. We can relate to this. We trust you. We can ask questions. I also talk about mental health issues. Then sometimes people tell me, well, of course I have also mental health issues, but I didn't dare saying so before. So we use terms and wordings that people understand. So people think that they really feel, well, perceived and visible. So people are able to do more because they realize that we walk the talk. It's not only about talking, but it's really about putting it into practice. So we really walk the talk. Mrs. Dirks has explained this during her presentation, that usually in patient trainings you have a professional teacher. And now the question is, does it really make sense? What about the other projects? Maybe we should use, well, a different perspective, different expertise. I think it's very important. In our groups, people, they really ask questions that they wouldn't ask their doctors or health practitioners. Well, let's say participants from our group would be here today. They wouldn't ask any question. It's really important to have a level playing field, to have a peer-to-peer approach. So you need peers. However, they need a certain training. That is true. And people feel less hesitant. And this is very close to reality, to have peers teaching a course, doing it together with the participants. This reminds me of a situation that I've experienced with the Down syndrome working group, where I, held a speech. There was one patient, Charlotte, and she said, "Thank you, Dr. Kösters, for this great presentation. Can you give this presentation in easy and simple language?" And I felt so ashamed because I was not able to do this. And it shows that we want to do the right thing, but it should go down well with the people that are affected, that are concerned. Mrs. Krug, well, when hearing what Mrs. Calotti says, well, this is underlines the success of the work that you've been doing for the past 8 years. So why can we not continue this project? Why can't we continue to provide funding? Because it's a good thing, isn't it? Well, we have a special role as a foundation. We can only provide limited funding. When it comes to healthcare systems, we cannot fund healthcare providers in the long run. That's what the healthcare system is for. At the same time, however, we as a foundation do not want to contribute to negative developments, developing new projects again and again, and then what we are trying to do is to kick off a project. So we have the privilege to take risks. maybe more risks than other actors would be willing to take. So we risk to fail. That is okay with us, but we choose projects where we see the opportunity that there will be continuous funding or follow-up funding. And I think when it comes to INSEA, I'm sure that this was a very successful project. It went down very well, very good results. And Mrs. Dirks has already mentioned it. If looking into our social code, German social code, there are different articles that would enable us to implement this program. And I think the years that we have spent with funding INSEA has taught us a lot. On the one hand, there's the phenomenon, and this is a strong suit of this program covering a lot of aspects. There is prevention, self-help, it's patient training, but this is not a good thing when it comes to long-term financing or sustainable funding. So as soon as there is, well, one body realizing that another body might fund this program, then they don't feel responsible. And then there are also new elements that our system hasn't seen before, and that is this broader approach across indications and tertiary prevention. And this makes it particularly difficult to introduce innovations. And of course, we have learned a number of lessons. We also feel a bit frustrated, but we haven't given up because it's an important program. So maybe we need a project in order to combine these different responsibilities and, well, embark on new path. Well, but basically, we as a foundation, we are also trying to rethink our approach. How can we enable more innovations? And of course, the guidelines of the statutory health insurance, they should open up. And if this is not possible, we need a political solution. We have heard that we might need an amendment to this article of this German social code. Mr. Krug, so we realized that this program definitely makes sense, and it has been going on for 8 years. This is quite a long time. And still, the Barmer statutory health insurance says, no, don't want to be involved in any longer. But how can we continue this program? Mrs. Dirks has already touched upon a number of aspects. I agree with Mrs. Melin. So this program is mature. It can be launched. So wearing the hat of the body funding the program. And my task is to fund the program as long as we've achieved a status quo. We enjoyed funding this program, and now it is a fully fledged program. And then we heard what Mrs. Dirks said, that there are a number of laws, a number of fields, rehabilitation, patient training, and there's always a catch. And if I were the head of the self-help funder, I think when it comes to self-help, there is a provision enshrined in our law that whenever a project has come to an end, but we want to continue the program, there could be a lump sum funding using the same setting. So this is a first suggestion that I would like to make. But then we need to change and adjust the program a bit, because there are a lot of aspects to INSEA. Well, it is working across indications with multiple layers. So we, as an SHE, we funded the self-help arm, and the foundation paid for the overhead. But this, well, needs some adjustments. And then we could present this project to one source of funding the whole project. Do you think there is a possibility to redesign the program in order to ensure funding in the future? Well, it really depends on how to redesign the program. We still need peer-to-peer groups, and we want to promote empowerment. And if it's heading in a different direction, then this would make sense. But if this is about adjusting structures, and how to improve quality assurance when rolling out the program, well, if there were new structures, that would be great. And if there were additional providers, that would be a good thing. We have very good partners for the time being, but if we can have new partners, adjustments would be great. But there are certain principles that we want to hold on to. Is this what you wanted to do, doing away with certain principles, or was it about the part played by the foundation?
Well, when I talk about redesigning it, I'm talking about redesigning its structure. It already has a coordination point. And if you were to continue this project in the context of self-help, if you were to keep funding it, it would have to be enshrined in this structure of self-help. By doing so, we would keep or maintain the peer approach. So it is a structural issue. How do you adjust the current project in order to adapt it to our current legislation? So we talked about self-help. Could you imagine redesigning the project on a structural level so to maintain the positive outcomes that we have identified? I mean, of course, we have to keep the DNA of the patient point of view. Well, I believe it's possible to do that. There are already self-help organizations which are doing that, so this is not completely new territory for us, but it would just be sort of a redesign and a reshaping of it. I'm just worried about the volume. I mean, by using the lump sum grant, I'm not sure whether we can maintain the program. We talked about 120 project leaders and even more users and participants of the project. And you can't just top this up or on top of the already existing projects that are being funded and supported by self-help. I believe it would pay off to find additional projects, and maybe we should think about this transitional period now, which we would have to be able to survive, because it would be too bad. It would be such a pity if this project were to die down. Mr. Schwarzer already talked about the political efforts in order to create a new sort of basis. I believe we would be able to cover the volume with regard within the context of the lump sum grant. So we disagree on that point. Still, there's something that I find quite worrying. We lack the legislative basis. We have the law to promote digital health literacy, something that was made up or launched by our former health minister, Mr. Spahn. So I would like to praise him on that. But nobody has actually launched a law on fostering literacy for self-management. So this is something I heard about here today. So I think that would be useful. And we have to ask our political decision makers about that. What do you think? Do you have a certain toolkit for that? Do we have certain institutions? For instance, there are some that are funded by the Federal Ministry of Health, and we would have to agree on certain transitional periods. So I believe we have a lack in terms of our legislation. So we started as a starting point with our statutory health system, and let's talk about how to adjust, change, maybe expand our social health system. We actually had a representative that was supposed to come here on behalf of the Federal Ministry of Health. We all know that COVID is still around. But Professor Dr. Amelung is here today, and I'm very happy about that because he's a professor for health management and health research at the Medical University of Hannover. He's focusing on international health system research. So let's delve right into that. Yesterday, I got to read in a newspaper that the tax-funded part in our SHI system has never been as high as it is today. And this has to do with COVID, obviously, but what is the future development going to look like if we talk about statutory funding? What is going to happen in the future? You are the health economist. What do you think is going to happen with regard to the SHI system? Thank you very much for this introduction. So we have been waiting for weeks on a draft for a reform of our statutory health funds system, and we expect that there will be a deficit of 17 billion euros next year. So we will have cuts in our benefits, and we will probably have a lot of changes that we're going to expect in the future, and we are going to take a look at how to cut costs in the future. So that means, of course, we have to take a look at our social code where it says that it needs to be appropriate. So we need to reevaluate our benefits and services, whether they actually pay off economically speaking. Of course, it is about a reasonable spending, and we should only spend our money where there is an efficient use, and we have to reassess that. And we have to see that we have to actually prove that there are certain benefits to medical interventions or the reimbursements. In my opinion, the SHI expenditure is just like spending tax money, and I believe we have to spend tax money on reasonable, proven means and not just things that you believe are right. And Mr. Krug this morning said that he's very happy about the fact that it is evidence-based, so it is a proven method. And Mrs. Dirks, Mrs. Schäfer and Mrs. Lorik proved that it is evidence-based and that there is proof for that. And Mrs. Lorik also showed us that we could be saving costs. Is that the language that is maybe more meaningful with regard to convincing political decision makers? I think we have to take a different approach here. Why do statutory health and funds are not really jumping on the bandwagon here? Why are they not joining eagerly this program? So we have to wonder, what's the weak spot here with regard? So what's the weak spot? Why are SHIs not catching up on to that new trend? And so we have to wonder, how can we generate even more clear evidence? This applies to other projects as well that deliver excellent results, and that makes it easier for us. So if we have these medical facts, economic facts that we can present, then we get the SHI on board. So let me sum it up. Number one, you said there is financial pressure on our SHI, so would they need to act? Secondly, you said we have to act evidence-based, fact-based. And if you were to prove that we were able to minimize costs using this program, then we would get SHI on board. And you said that we need these two partners on board, and we can only get them on board by showing that there's enough evidence. Mrs. Dirks, are these the prerequisites that we need for political decision makers to convince them that this is an essential component to tackle the ever-aging population that is suffering from more and more chronic conditions. I think that was a great summary of our discussion this morning. I mean, the facts are evident. People tend to often argue that the controlled studies were carried out in the USA, and now they have to repeat that in Germany. So let's take a look at the cost-use analysis. From my opinion, point of view, if we talk about this transitional period, from a scientific point of view, we have to focus on that more controlled approach. Secondly, we need to have an economic assistant research program that we launch. And then thirdly, we have to focus on the specific points. It is a comprehensive program that is working with people with different restrictions and disabilities. For some people, hospital stays are not a good proof for success, and for others, it is a good factor of proof. So we're trying to answer these questions. And last but not least, Mr. Krug broached the restructuring of INSEA, CDSMP. Well, we have the indication-specific further developments that would be useful to maybe pursue that approach, and this might be a positive contribution, and this might be worth redesigning in order to make sure we secure funding. Mr. Kösters, may I add something? So from our point of view, or from the point of view of self-help, I would like to raise awareness for something that was not talked about yet. When we talk about self-help in addiction, we publish statistics on a regular basis that are generated by the organizations. And I would like to point that out now. Out of 100 people suffering from an addiction, so I'm talking about alcohol now, because that makes things easier now. So out of 100 people suffering from an alcohol addiction, about 20% end up in self-help, and they become sober. So nobody's aware of that, because nobody's studying these statistics. And what does that mean? A doctor will perform a surgery on me if I have a certain physical issue. He's going to treat my addiction. And this is recognized by the SHI. But a self-help group is part of a complementary component of the system. So we have our official care system, and the health self-group is just a complementary bonus or component to that. So I just talked about the statistics. And this just shows that we have quite a high level of efficiency, which also leads to minimizing costs. Whenever people go to these self-help groups, I have to underline that they are being held on a voluntary basis. I believe we have our official institutions, but we have never taken into account the experience of our patients. Yes, I believe these lived experiences can be a solution and hold a lot of power for solutions. So later on, I would like to let our virtual viewers know you have the opportunity to ask your questions, to post your remarks in the chat box. Mr. Danner, I would like to go back to the indication-specific component, which might be part of the funding. I'm taking this home as food for thought when we have our cancer and AIDS self-help group, our pain self-help groups here in Germany. What else was it? Oh, I think also the diabetes associations. I'm going to put them all on my checklist. I'm going to approach them because we already have data and evidence for them, that might be helpful for them. And this might be a good starting point. I believe our associations in the respective fields might start thinking about how to integrate this program, and maybe the SHI could fund some sort of evaluation program so that we might be able to foster it. And in terms of diabetes, I believe that this goes beyond self-help group, because if I could take a look at diabetes, there is a lack of patient training programs. And so this tool is actually not used. And many patients do not know that they have certain tools. They're not aware of that, because self-management is supposed to be part of the disease management program. So they don't even know that they're part of these DMP programs. So I believe this might be a political option. There is a great dissatisfaction with regard to the implementation of the disease management program, and maybe the DMP approach might be a good one to integrate this, and we might think about transferring certain aspects of the program into our DMP. So within the SHI program, we need to find options for funding, and we should appreciate the knowledge of our patients. And should we launch certain campaigns to do that? Should we launch campaigns to raise awareness amongst politicians, amongst the public? What do you think is necessary to foster some sense of being more open-minded? I'm not sure whether an individual campaign might be able to raise this awareness. It's more about changing the understanding of the role of the patient. For many years, we've been talking about patient empowerment. Let me just spoil that for you. Patient empowerment does not always mean actual patient empowerment. Sometimes it's more about compliance and adherence. So appreciating expert knowledge, that should be part of changing the role of the patient. So let's take the bigger picture here. Let's not just think about the SHI. Let's talk about the facts and figures as well. I mean, we already have plenty of data on minimizing costs in the health sector. So SHI would love to know, what's the difference now, using the INSEA program or not? What cost benefit do we have? Unfortunately, we have not enough data on INSEA yet, how many resources you can save. So we need more data on resource saving as well, and how in a more versatile way you can use resources. Let's think about that. You just need a room. You don't need any more resources than that. You don't need expensive technology. You don't need expensive devices. Let me once again advocate for this project. I mean, there are non-monetary aspects that are relevant for INSEA. It has to do with justice and equality as well. If you just talk about indication-specific programs and trainings in this SHI program, you always talk about the most prevalent diseases, cardiovascular diseases and diabetes. And those patients affected by very rare disease are usually marginalized and excluded. So this has to do with equity and justice as well. We need to make sure we have this kind of equality, and it needs to be open for all patients, also for those who are marginalized. I believe statutory health funds are not the ones who should only be taking care of that. Of course, they are bound by economic guidelines as well. In my opinion, this is up to the political decision makers. They need to implement this kind of justice and equality. So we need to save resources on a social level as well, and this cannot just be reflected in individuals' social health funds. We also talked about life quality, which cannot always be measured in cent and euro or in a certain budget. Mr. Amelung, if we want to convince our politicians, if we ask for political change, based on your experience, what might be helpful to do that? Give us 2 to 3 pieces of advice. You need facts and figures. You can evaluate complex issues as well. You can have a modular evaluation. It doesn't always have to be a scientific one. We need to take a look at the effects. We need to understand them. We sometimes need studies. I think there are already excellent studies. It would be great to have more studies on that. Secondly, I think we need to find the right partners. We need to establish the right partnerships. We need the right kind of advocates. Why is digitization not working in Germany in the health sector? Because we did not manage to mobilize physicians in Germany. They are not backing us up here. Same applies to our issue. We need to find the right partners, stakeholders. We could talk about social health funds, maybe service providers, foundations, individual politicians, such as the patient representative, who was very encouraging today. But we could also get Allianz Health Literacy on board, or other organizations, patient organizations, advocacy groups. So we need to enter into the right coalitions. We need to establish the right network. What a great piece of advice. Are there any questions? I'm going to give you the mic. I'm going to hold on to it. Oh, there's some hair on the mic. Okay, I guess we got it. My name is Theresa Keidel. I'm the head of the Self-Help Coalition in Bavaria. So we have joined INSEA in 2014. We're very convinced and we're happy about this project. We came here as a group. But I would also like to talk about the funding of self-help. This is explicitly meant for self-help. And self-help adds a great benefit to the society in Germany. 1 to 7, that's the ratio that was already identified. But funding INSEA in that context of self-help, that's quite dangerous, because self-help needs all the funding it can get for itself. INSEA is great, tested and tried, works well, but self-help funding cannot cover the overhead costs and the access to INSEA. In Hanover, it was particularly successful. This INSEA was addressing all of the patients, and we should not give up on that. Funding INSEA via self-help would be extremely dangerous, and I'm not in favor of that. Mrs. Dirks, we talked about opening doors today and about closed doors. This morning, we opened a door and it seems like we closed it again, and then we would like to talk about other actors as well.
Für dieses Thema zu gewinnen.
Do you think there's a possibility to get other actors and players on board? Well, I don't know what the stakes are. It took us 7 or 8 years, and there were a lot of closed doors, so to speak. But of course, we will always try again. I share this concern that the money that should be spent on self-help is spent on something else. But what I wish to see is it would be great to have regional INSEA structures. We started out with the ports, the health centers, local health centers. And then we would have different partners, because in this case we would have health services providers. And this is something that we haven't really implemented yet. And I hope we can change this in the future. Otherwise, of course, we're trying to open other doors. We are always looking for new doors to open. And today is a great start, actually. Well, I think this is very encouraging to hear the political statements that we've heard. There will be great discussions, and the DMPs, this is also important. Well, whether it's indication specific or across several indications with a cross-cutting approach. So there are sometimes some doors that might not be open, but they are ajar. So if we had a patient foundation the way we would wish to see it, then there might be some spot for self-management classes. So we have to forge more alliances. So it's really up to you to find more players, because I'm sure we have all social networks that we can use. I have one more idea. The current government coalition intends to open up health desks in socially disadvantaged areas. So I think INSEA should have been implemented already. This would be the right place to do this in order to find a place for INSEA. This is what the coalition wants to do. I talked to Mr. Ullmann from the Liberals, and he was really enthusiastic. And if the Liberals think it's a good idea to have a health desk in socially disadvantaged areas, I'm sure it will happen. So this would be an option that we might want to explore. Thank you very much for this great idea. There is not only the Barmer Statutory Health Insurance Trust, there are others too. So today's conference is also supposed to show you what is our status quo, what's the current situation. I'm a representative of statutory health insurance, but I'm not a healthcare system expert. But today this is a plea or a call for finding out whether there are more actors or players that we can reach out to, because we are not cannot always look for open doors. I want others to approach us and showing that they're interested in that project, no matter what articles may be helpful here. So this is the idea, reaching out to others. The doors are open. Prevention, self-help. There's one thing, Mrs. Carlotti, that we have discussed about, but then they said there's no point in professionalizing this or using fees. This is a great project, but you need to pay a fee. What do you think about these fees? Well, personally, I was retired at the age of 35 years old, and I received social benefits, and it would mean I just couldn't go there. I couldn't attend these classes. So this is what we need to bear in mind. Mrs. Schäfer told us that health literacy is very poor in a number of areas, especially among people with a poor education or that are socially disadvantaged, especially if we have overlapping factors. And when we're talking about these people, and Mr. Danner said, even if the Liberals say we would like to spend some money on socially disadvantaged areas, the thing what we need to do is, this is the time to give it some food for thought